You can sit wherever you want. Have a seat wherever you like. Do you want to? Okay. Okay, everybody, welcome back in. We have a slightly amended schedule, but we're going to jump right back in and do our thing. This is not a couch chat. This is an armchair chat, but we are going to have an armchair chat here talking a bit about bridging the divide. I'm Zach Rosenthal. I lead the Duke Center for Misophonia and Emotion Regulation, and I have a partner with misophonia, and that is something I live with each day and have for a long, long time, and understand misophonia through that lived experience. I also do a lot of research, teaching, and clinical work and advocacy to support this community. So I'm going to ask each of you, I'm actually going to sit down. Maybe you can have this. So I'm going to ask each of you here essentially to introduce yourselves, and in introducing yourselves efficiently, address the topic at hand. And the topic at hand is bridging a divide. The thing that is missing from this title is that really it should be plural, in my opinion. There are many divides to bridge. So I'm going to invite you all to think here about, in the space that we're in, with lived experience, with clinicians, with researchers, apropos of the whole point of organizing this event, trying to learn from each other and really kind of identify gaps and areas to overcome these gaps. What do you each see as, so introduce yourself first, and then maybe say something briefly about what kind of divides you see as really valuable from your perspective, whichever perspective you choose to answer that from, and what kind of bridge or bridge materials or whatever you want to do with that analogy. What do you see are some of the solutions? Maybe just offer one in the sake of time. We're going to go through each of the four of you, and then we're going to go to our Zoom audience first, and then we'll then open it up to you all here today. Dr. Fox Thomas, you are sitting next to me. Would you like to go first?
Am I on? Can everyone hear me okay? Hi, everybody. I'm Lisa Fox Thomas. I am an audiologist, and I currently work at the University of North Carolina, Greensboro Speech and Hearing Center, where I have had the privilege of working with children and adults with misophonia for over 15 years. I offer a range of intervention services and supports, including sound therapy and biofeedback and some other things. Of course, refer to my colleagues down the street and have other, you know, options for patients, because I really do feel like it's important to provide people with misophonia options that some may fit, some may not fit. So I guess I look at the divide or the gap in services from my perspective as an audiologist as, really focusing on the journey that you all with misophonia take to find help. That's been really something I've been thinking about a lot lately, and what that looks like, and how many professionals you may go through on your way to find those of us who actually maybe have a working knowledge about misophonia, and how frustrating it could be to feel dismissed, or if you've seen one audiologist, you've seen one audiologist, maybe there's another audiologist out there that has a better opportunity to help. So I really would like to learn more about what that journey looks like, and how we can facilitate making sure that people with misophonia get where they need to go, and find the supports that they need.
Hi, everyone. My name is Andrada Nakchiu. I'm a clinical psychologist. I work at Duke University. I'm a researcher there, an associate professor. I started working with misophonia because my office is next to Zach's. And he kept talking about this. And yes, just like that. So I got interested to find out what it was all about. My primary research interest before misophonia and also right now is around emotion dysregulation across disorders and how people generally manage their distress. And this kind of fit right in because it's about distress, even though it's very different than emotion dysregulation. So I started to write grant applications and think about this more. I had a couple of patients with misophonia as well. And as I'm starting to do this work, I'm telling my family, like, hey, I've started to do this thing, and no one, I'm Romanian by origin, no one in Romania knows about misophonia. And I'm describing what I'm doing, and my sister says, oh, I have that. And I had no idea. My sister's 5 years younger. We grew up together our whole lives, and I had no idea that she had misophonia. And she was the difficult child in my family, and the like black sheep, and all of the really judgmental terms that I've learned since we all use about people with misophonia all the time. So I have a much better understanding of my sister now and the difficulties that she said. She'd never mentioned it to any of us ever before I actually said that I was actually working on misophonia, which was very interesting to me. Currently, what I do is I do treatment development research in misophonia. I'm one of the people who use the magnets, the transcranial magnetic stimulation. And the reason I got into that space is coming as a clinical psychologist, I have a lot of appreciation and love doing psychotherapy. And I think psychotherapy is so powerful and important. And at the same time, I was frustrated as a therapist with how slow progress is sometimes in therapy, how much work my patients have to do to get to the place where they need to get. So from that perspective, my interest is there anything in neuroscience, is there anything in technology that we can use to power up that process, to make it faster, to make it easier? And I try to use neurostimulation for that, not neurostimulation by itself, but as a kind of like a tool to put wind in your sails when you're trying to do the hard work of behavioral therapy. Gap, because that's the question I'm supposed to answer. So a gap that I see, I think it's twofold. On the one hand, just like you said, I don't know what to say to people oftentimes when they ask, what should I do? I found you up online. I typically send them to Zach, which is great. But I found you up online. I see you do work in this space. What can I do for my child? Or what can I do for myself? I get people from Romania messaging me, asking me, what do I do? What do I do for my patient here? Because I think they have what you're describing, but we don't have any tools. And there's so few resources. And that is heartbreaking because while we're developing all this work, people need something right now. They need to know what to do right now. And I really want to see us getting better at covering that gap. Another gap that I see is from the research side. These kinds of meetings are great because I get to hear about people's experiences, and then I kind of go back into my lab and into like the variables and designs and all of those things, and everything gets very simplified because that's how research designs look like. And you miss a lot of what actually lived experience ends up being. And I really don't want to miss people's experiences. So I think continuing to have conversations so we can get out of our variables and numbers and boxes and try to make sure that we're not missing an important part of what is described through lived experience when we're doing the research that we're doing, I think is very important. One approach that I've taken for that, because you also want solutions. So my solution for resources is just send people to Zach. My solution for the research gap is to really think about our stimuli and how to get them as close as possible to people's experiences. I think, again, as researchers, we're taught to have standardized approaches to how we measure things. But there's nothing standard. I mean, Jamie's going to disagree with me. There definitely are commonalities, but there's so many differences in the types of stimuli that bother people with misophonia. And I think we really have to keep that in mind when we design our experiments for misophonia, because otherwise we might be studying something very different than what misophonia actually is.
Hi, everybody. My name is Nick Davidenko. I'm a professor of psychology at the University of California in Santa Cruz. And my area of research is in perception, and I specifically study what's called high-level perception, which includes concepts about how perception is multisensory. So we don't have just a visual system, an auditory system, tactile system, but they work together, they're integrated, and they interact. I also study how attention and top-down effects can affect perception. So your beliefs or expectations can modify how you perceive something that's ambiguous. And one of the things I also study, which is very common in perception research, is vision, visual perception, and how vision tends to be a very dominant modality or sensory domain. And the way I got into misophonia research was through that basic research experience of multisensory perception and how visual stimuli or imagined sources or beliefs about sources can affect people, the way people respond to sounds in an effective way, affective way. So I think getting to divides and gaps, I think there's challenges in going from a basic researcher to doing research that's clinically oriented and translatable, because as researchers, we think a lot about very carefully controlling experimental conditions and stimuli. But in this kind of work, there's other priorities that might be even more important, such as seeing that something works, which might result in different choices in how we design experiments, how we carry them out. And then one more thing I'll say is about research dissemination. So as a researcher, we think about usually a publication as the final state of a project. I published it, that's great. Hopefully someone will read it and even cite it someday. That's like success. But it feels like we have a more urgent need to disseminate research as it's happening in a broader way in this field, because we need solutions before we can solve all the problems.
Okay, I probably don't need to introduce much about myself. You've heard a lot more than I would normally say about myself. So I'm just going to jump to the divide. So I think that one of the biggest challenges from clinical research in general, and particularly psychological research, is this problem of doing therapy or intervention treatment trials and not thinking about, like, a treatment trial might look perfect when you're running it, but it's not perfect if it doesn't apply to the real world, and it's not perfect if it doesn't reach the people who need it. And so I think that's the part that I'm most interested in terms of the divide, is some of us at least need to be doing less perfect research, compromising on perfect research to be able to have the biggest impact that is possible, but also thinking about, we don't need to come up with the best treatment. Maybe we also need to come up with the thing that is going to be able to reach the most amount of people.
Different divides observed, right? Different divides. I think it's noteworthy to highlight that there really are a number of different spaces where there are key divides, key gaps that you each highlighted and need to be addressed. If you could identify, let's imagine a world in a year or two where the most important divide from the lived experience community back to you as a researcher or back to you as a clinician, or the opposite direction, you as a clinician or as a researcher back to the lived experience community. If you imagine a year or two from now where that there's real solution in place that has materially changed how things are, what do you envision that looking like? Any version of that. And I'm interested practically and kind of tactically and concretely, and I'm also interested in what the lived experience folks here and online have to say. How do we build structures? How do we really build sustainable structures that are bidirectional or tridirectional? What would you like to see there?
So I have really been thinking about the need for, misophonia collaboration networks that cross clinics that are, specific to different geographical locations. Because, a lot of you may know that those of us who are clinicians, we're licensed in the state in which we practice. And you have to be in this, we have to be licensed in our state, but we also have to be licensed in the state where you are. So I can't practice across state lines without being licensed in that state. I do have people who come see me, and then we can, try to do telecare and that type of thing if I'm licensed where they are. But the biggest, I think, thing that we need are different professionals who are interconnected, who are willing to see the same people, and that we have a shared data system that we can easily share data with each other without having to sign a billion forms trying to get reports, facts, and all of that, and that can be done asynchronously, because trying to get our schedules to all align to meet, and collaborate about a patient, I think is really tricky. So I would just love to see some sort of database where someone like this family over here that lives in Indiana, can reach out and say, I have a child who's this age. These are our concerns. This is what I'm looking for. And then it could somehow give them sort of a path of providers that they could see that we could all work together to try to help, so that they're not in the situation of not knowing where to go or what to do or what next step to take.
In a year or two is hard. A year or two, okay. So in a year or two, I would love to see more teaching in schools for therapists and psychotherapists about misophonia. And again, we don't have the treatments yet. We're working on those. But just like Deepika was saying, we have a lot of elements that I think would be helpful. So there's that knowledge that I think would be really easier to disseminate in schools, in training programs, in that the people who are coming into the world as providers. It would be great if they already knew about this condition and how to approach it. I don't know if it's doable in a year or two, but that would be fantastic. For the other gap that I was talking about, I love the So Quiet group, because you can ask them questions and they'll tell you what they think about whatever it is that you're doing. It would be great to have communities like that where we could engage a more diverse sample of lived experience, so we can actually make sure that as researchers we are doing what's needed, we are answering the right questions, that we're representing everyone's as much as possible, everyone's needs, and not just the needs of those who reach us. Again, I think it's been talked about before, our samples are pretty skewed currently because of resources. We reach the people who have resources to reach us. And it would be great to the very least be able to engage across the country with communities that don't look like me, who can tell us, what you're doing is ridiculous, I need something else, or no, you're on the right path. I think I want to see it go into kind of this direction. I don't know how doable that is in 2 years, but that would be lovely to see.
In a couple of years, I think misophonia is going to be much more well known. Even just some of the trends that were discussed today, from 15% to 34% people who have heard of it. And I think that I'm also expecting to see a lot more research from around the world about how misophonia manifests differently in different countries and different communities. And I think what I hope that these kind of meetings and more meetings like this will keep fostering communication and collaboration between researchers, clinicians, and lived experience community, because I think we can all learn so much more from each other than what we tend to do on a daily basis.
There's a term you used there, Zach, that sort of zeroed my thinking here about the idea of, we call it two-way engagement when we're thinking about how we put our research out into the world. And if we're talking about a 1 to 2 year timescale, I think that's possibly one small change that is possible within that time frame for us as researchers. When we've got our results, that we would take it to a group of people with misophonia and ask them what they think it means. And we would incorporate that into how we write up and share the work that we've done. And we would ask them, what do you think we should do next? What are the unanswered questions? And that's something that we can do straight away, because we all have results that we could share with the lived experience community, and that would be a two-way process.
Wonderful ideas. Wonderful ideas. We're about to shift over to the Zoom Q&A here. So let's make that transition. Dr. Brout, if you are with us,
I
there you are.
am with
Hi.
you, Zach. Hello.
Excellent. Take it away.
Okay. For Lisa, how is somebody to find or let me rephrase this. How can somebody find out what can they say to a provider to understand whether or not they can screen for hyperacusis?
Okay, so hyperacusis, as I think was defined for you earlier, is a reduced sound tolerance to specifically loud sounds. And sometimes there's an interaction between volume and pitch. So a lot of times we do see they're more sensitive to certain pitches. So you would need to find an audiologist who can measure what's called loudness discomfort levels. And so that would be a procedure where they would determine, what is the loudest sound that you can tolerate at different pitches and look at that profile and tell you if that is within the reduced sound tolerance range or the hyperacusis range. Anything less than 70 decibels is considered hyperacusic. So that would be the question to ask is, can you measure loudness discomfort levels?
If I may, Jen, real quick, Lisa, what should people be looking for when they're trying to find the audiologist who can do that? What search terms should they use?
So I would say that, a lot of audiologists who are trained in tinnitus management, sound sensitivity management, those are going to be your audiologists that would have that skill set most likely. Any audiologist should be able to do that, but in terms of specialists, usually it would be someone in the tinnitus sound sensitivity realm that I would think would be able to do that evaluation.
Thank you. Jen.
Yes. One of
Next
our
question.
anonymous attendees here has pointed out an excellent gap, I feel, in both the research and clinical work, and that is what advice or how can we forward the research in terms of couples with where one person has misophonia, so romantic relationships versus kids with misophonia or parents with kids with misophonia, and also they want to know what advice you can give and how you can forward research for parents who have misophonia, not with kids with misophonia.
Boy, that's a loaded question. Okay, I think a pretty obvious gap is that we just need to do a lot more treatment research. I didn't want to say that because I think it's an obvious one, but that's an excellent question around how we need treatment research for couples. We need treatment research for families. We need treatment research for parents. We just need to do a lot more treatment research to be able to answer these questions in an empirical way. Without that, it's hard to know exactly what to say and what to do in those situations. Again, an educated guess, what I would do if I was faced with a situation like that would be to say, again, finding a provider who knows how to use cognitive behavioral principles or acceptance and commitment principles, because we have some evidence that those work, and really being descriptive in what exactly are the things that are problematic, what are the goals, how would life look different, how would life look better if things were changing, and using some of those principles to those specific problems and kind of working together with that provider to reach what we call a life worth living, to reach a place where maybe the problem hasn't gone fully away, but the weight is lighter, like it was said before, or you're able to manage that particular difficulty in a different way in which it actually works for the couple or the family. Same for parents who themselves have misophonia and their children don't. We have people like that quite often in the studies that I run, and it's soul crushing because you have this intense reaction to your child who, it makes no sense that your body's having this intense negative reaction to your child who you want to teach and love and protect and all of that. But it's still, again, it's an emotional reaction. So in the absence of knowing exactly how to treat that particular problem, I would still do the same thing. Try to break that down and, how does it happen? When does it happen? What can you do about the thoughts you're having, the emotions you're having, the physical sensations that you're having, and learning skills to manage that distress. And it's possible and it's doable and it can absolutely help lead to a better quality of life while we're waiting for more research to show up and give us more exact answers.
I want to just make a comment about the couple aspect in particular. So I think we often think of couples therapy as when there's a problem with the relationship, and there's a type of couples therapy called behavioral couples therapy, which is specifically for people where the relationship is integral to the problem, or the problem is integral to the relationship, but it's not a relationship problem. And so if that's the case, then that could be something that you could search for is behavioral couples therapy. And if someone's trained in that, they may be able to support you more effectively than a general couples therapist who would be looking to help with the relationship itself.
Jen, any more questions?
Okay.
We'll maybe
You're
do one
looking to the
more.
left, but I think you're in front of me. Okay.
Let's do
Yes.
one more from you. And then we'll
Okay.
go to the room.
Can you refer to misophonia as an official disability? Can you say that to an employee? And where do we stand in terms of diagnostic manuals?
I can only speak for the UK. Disability is needs-based, not diagnosis-based. And so it depends on how disabling it is for you. So that's a really important thing. But knowing that doesn't actually mean that people are going to listen, which I think is the most heartbreaking thing here. So that's all I can say really about that.
Very hard for me to inhibit on this one. Even though I'm the moderator, I'm going to respond. Under the Americans with Disabilities Act, misophonia is covered. This is something you can find online. You can look it up in a quick Google search. You'll find the website to support it. You'll also find documentation and supportive tools on the So Quiet website to support how you go about the process of working with your employer if this is something that you wish to do to receive accommodations due to misophonia as a disability. In terms of diagnostic code, you can't refer to it as a diagnostic code in the ICD in the US yet because it's not in the ICD. It is currently under review, actually both in the ICD-10 CM, which is what the US uses across all medical services, all providers of all healthcare of all types, not just mental health, use in the US the ICD 10 CM. So it's under review there. It's also under review in the ICD 11, which is used by 45 countries, but not yet the US. So currently under review, and stay tuned. Let's transition, Jen, if that's okay. Thank you for moderating the Zoom questions. We're going to transition here to our live group, and we'll just look for any questions for the panelists here, or any comments for the panelists.
Thank you. The National Institute of Mental Health had the RDoC framework, which a lot of people are familiar with, this dimensional framework, transdiagnostic approach. How much has that influenced clinical practice in mental health, in psychology? Now, the NIDCD, National Institute of Deafness and Communication Disorders, does not have a transdiagnostic framework or influenced by RDoC in any way. Is that a barrier to some of the research that's going on in audiology? And I'm just curious about thoughts about audiologists and psychologists working together for in kind of an integrated practice unit, and how that would, how that can be implemented.
I would say that, a lot of it does depend on, where you work. Where I happen to work, I don't have audiologists on staff that I can work with. So that's where, we definitely have people in other practices and in the community that we can refer to. So I can't really speak to the rest of your question with regard to the transdiagnostic piece.
So the transdiagnostic piece for mental health, I think was a really great idea. Exactly how it was implemented, it's a little questionable. But it comes from a good place of thinking about disorders in the mental health realm, not as categorical objects, and the way we diagnose them, not based on some arbitrary list of symptoms that someone observed 50 years ago and decided that this is the label we're going to put on these things that are together. I think there's a lot of problems with our diagnostic system. And the idea behind the RDoC came from trying to break away from those problems and categorize problems in a more organic way based on kind of units of difficulty or units of problems, units of distress. How exactly it was implemented was based on very, very biological models and animal models. And I think, again, human experience is a little more complicated than that. So a lot gets missed when you try to simplify disorders and mental health into what you can only observe in animals. So I think there's a lot to learn from there. On the one hand, I think it pushed a lot of psychologists and treatment providers towards thinking about transdiagnostic treatments. And I think that's a great step forward. That's the space that I work in and a lot of other people work in. And I think it's helped us think about not just depression and not just anxiety, but what are the units that go behind that and how can we approach those so that you don't have to teach 50 treatments to a new therapist, but you can teach them 1 or 2, and then they're going to be competent in solving problems for more people, which could make dissemination a lot easier. It would be great to see that in audiology. I don't know a lot about that, but I think it would be great to think about an approach like that. I think the other lesson to take away is don't oversimplify the process, though, because once you define those, what are the common units of analysis, what we can learn from the mental health field, from my perspective, is that if we oversimplify, we can, again, lose important elements of what maybe treatments when we had the diagnostic categories were capturing, but now you're losing because you're trying to do this transdiagnostic process. I don't know if you guys.
Thank you for the question. Great question.
Just wanted to comment a bit on it. So I've been studying tinnitus for 20 years. And in that context, there are already established relationships between clinical psychology and audiology and between PT and OT and audiology. So I don't know if we need to reinvent the wheel, but there are established those relationships, those interprofessional kind of associations. I know it's challenging for individual practices, audiology practice, but certainly within the VA, for instance, the Veterans Affairs, there are those kind of things already available, and they're right. And within large hospitals, they are very much available. So
I don't want to put anybody in here on the spot, but I do really at the same time want to invite people who maybe are from lived experience community here in the room. If you have any questions, I'm noticing, I'm a psychologist, so I notice trends and patterns, and I'm noticing that there tends to be, if we did a statistical analysis, we might see that there's a higher probability that the researchers in the room who are more comfortable probably holding a microphone and speaking are the ones doing most of the questions. So I would like to invite anybody else in the room, if there is any questions or comments for the panelists, specifically thinking about divides in the lived experience community, back to research or back to clinical practice, or any divides you see.
Thanks for asking and taking this question. I noticed from the folks that spoke from lived experience today, there's a lot of discussion about emotion, shame, that sort of thing. And maybe that's something you can't measure as a researcher, but it is something that's a part of my everyday life and something I have talked with various therapists about and really just didn't get anywhere. So if there's any room in your research or something you would have to say about that, I'd appreciate it.
Shame is my jam. I so hear you. We hear so many stories. And again, my own sister, right, who didn't share anything for 20 plus years because of shame. That was the primary driver behind her hiding things. So I can't imagine how much of that comes from living in an environment or where you can constantly have experiences that other people don't have that would automatically get you rejected. We think about shame as a fear of rejection, of having other people kind of kick you out of the village and trying to keep whatever it is that would get you kicked out of the village private so you can stay within the village. And that's the definition, right, of what happens so often with misophonia experience. That you're afraid that other people might not understand, and often they don't, what you're going through, and then they would reject you, kick you out of the village, invalidate all of those different things. So the bad news is that I understand how much shame comes with misophonia, probably, and I also don't understand as much as people who are actually going through it do. The good news about it is that we have so many treatments for shame. So in my previous life, I was doing a lot of work with borderline personality disorder, where there is a ton of shame for a very different reason, very different problem. Not trying to equate the two to make them the same. But we have a lot of thinking and knowledge and treatment tools to approach what to do with shame. And how we think about it there is to identify, is shame justified or not justified? Justified meaning, are the facts support it? Am I going to get kicked out of the village? Sometimes they do. And in that case, learning how to effectively problem solve, how to stay in the village. And sometimes they don't. And then we do what's called opposite action, trying to act against what shame tells our body to do in order to reduce, to get our brain to learn that this particular experience won't get me kicked out of the village. Right? So for my sister, probably keeping it quiet as she was growing up was very adaptive, because probably my parents would have made fun of her, honestly, knowing them, but much as it breaks my heart to think about that. So she was solving the problem by, avoiding and trying to not tell us about it and leaving the table and doing all of those things. Once we learned more about it, shame no longer became adaptive because I understood what she was going through a lot better. And so hiding things was no longer something that would get her necessarily made fun of, but on the contrary, could actually help us problem solve how we can sit together as a family in an event. So actually talking about it would be the opposite action, would be the thing to go against the shame, assuming that that experience of being invalidating does not happen. And hopefully it didn't when she was talking to me about it, and that made shame go away a little more.
I think we are at time, where I'm seeing the red up here. You see a red thing telling you you're over time, which is a little intimidating. So I'm going to ask Lauren, can we do one? Okay, good.
Again, I'm asking on behalf of my 10-year-old daughter. So I've been speaking with a few people about using AirPods or earplugs, and she wanted to know, will it make it worse over time? It's the best coping strategy for her now.
I was wondering how long it would take for someone to ask me that question. It's very common for people to cope however they can to live their lives. So I totally understand why wearing of earplugs or using things like AirPods, noise canceling headphones, can be helpful. My own daughter is on the autism spectrum, and she does so. I caution people that I see about when and where and how much they use those types of things. So I think there's definitely a time and place for those things. If it helps participate in certain activities, that it's okay to do. But there's good research to suggest that the auditory deprivation that occurs to excessive use of earplugs can make you more sensitive over time, and it can be as short as a week, can turn up central gain and can make you more sensitive to loud sounds in particular. So that's where sound therapy comes into play, because sound therapy engages the brain in a different way. It helps to buffer some of the trigger sounds while introducing sound, not necessarily taking sound away. So that would be our approach to managing misophonia. So I would just definitely caution folks, about how much and how long they're wearing earplugs on the daily basis.
I have some research that is very fresh. Over 2 years, the use of earplugs, white noise, background music did not make things worse over time 2 years later. And there was a difference between using strategies like that enable you to keep going with your life, to participate in what's happening, compared to strategies that removed you from participating in life. And the ones that kept you participating didn't make things worse over time. And so the only caution is not to wear them all the time, because that can have a rebound effect in terms of auditory sensitivity. But in terms of your misophonia, using it when you need it didn't make things worse over time.
Okay, thank you. So I know we have another comment, but please, we're going to have to break now for lunch. We will continue these conversations after lunch. And as a matter of fact, after lunch, we are going to break out into groups and do some small group discussions and brainstorming around action items and needs and gaps. And so please keep these thoughts in your mind. The lunch is available on the roof, so you do need to take the elevator up to the roof. It's labeled on the elevator. It's a boxed lunch. Feel free to take the lunch, eat up there if you'd like, take it elsewhere if you would like, but please come back at 1:30. We will begin at 1:30. Thank you to the panelists. Thank you, Zach.